Welcome to the first Breakfast with the Expert for this spring semester and for this year. So today marks the start of year number 5 of the Breakfast with the Expert program. Our first Breakfast with the Expert was back in February 2011. And over the past 4 years, we have been very fortunate to have with us a wonderful group of experts who took time out of their busy schedule to come to Lamb Hall to share their advice with our students, to talk about their career paths, and to discuss emerging issues in public health and healthcare. So we've really been fortunate in that regard. So when we thought about how best to kick off year number 5, Silas was the obvious choice. A 2-time graduate of our college, Silas exemplifies the very core values of this institution. And by that, I mean his commitment, his passion about public health, his interest in helping others, his hard work, and his integrity. And it is those qualities that have made him one of the most liked and highly respected graduates of our college. And it is those same qualities that have helped him advance his career at a phenomenal rate. Soon after completing his master's degree, Silas joined the ETSU College of Nursing, and in almost no time, he was recognized as a rising star and asked to become the executive director of the ETSU Community Health Centers. And I learned this morning that there are actually 5 community health centers that he currently oversees. So we are very, very fortunate to have him with us this morning, again to share with us his current work and to provide our students with some tips and advice to help them advance their career. So thank you, Silas, and we look forward to your talk.
Thank you. Thank you, Dr. Corey. It's a pleasure to be here with you this morning. As Dr. Corey said, my name is Silas. I did graduate from the College of Public Health twice. Maybe it'll be a 3rd time. We'll see later down the road. I think I have my hands full right now. The BRPH program is feeling well. So you'll have to bear with me this morning. I was up late last night preparing, and then my daughter, my 4-month-old daughter, decided that she was so excited that Daddy had a talk this morning that she wanted to stay up all night. So anyway, so I'm here this morning, bloodshot eyes. I've not been smoking, just not been sleeping. So, but anyway. So I'm going to talk to you this morning about health centers, what they are. I think a lot of people don't know. I'm still learning what health centers are. And so you get handouts this morning because real world stuff happens, and I don't have a presentation for you. And so anyway, so you can look at your two handouts. One is a snapshot of our clinics here at or over at the College of Nursing. I'll just give you a little bit of background there, and then we can dive into what our community health centers, or federally qualified health centers. So this little snapshot here. Let's see. In the College of Nursing, we have 12 nurse-managed health centers or nurse-managed clinics. Those fall under the Office of Practice at the College of Nursing. And 5 of those clinics, I was explaining to Dr. Corey, 5 of those clinics receive federal funding from HRSA and are designated as federally qualified health centers or community health centers. And those 5 community health centers, 3 of those are here in Johnson City, Many of you probably have heard about or maybe even been to, hopefully, the Johnson City Community Health Center. It's across from the Johnson City Medical Center behind Woodridge Hospital. And that's our largest facility. And then we have 2 more here in Johnson City, and then 2 up in Hancock County, up in Smeadville. It's about 2 hours away. So those are our 5 community health centers, and the nurse managed clinic network at the College of Nursing is actually one of the largest nurse managed clinic networks in the country. Kind of serves as a model for a lot of other schools of nursing that have clinics. Nurse managed clinics just means that it's run by the College of Nursing, and all of our providers at our clinics currently are nurse practitioners, advanced practice nurses, certified nurse midwives, and we have a couple PAs. We also have some, not full-time, but we do have some physicians. We have a infectious disease doc that works over there a little bit of the time as well. So that's kind of a snapshot of what the College of Nursing nurse managed clinics are. So we're going to focus this morning on the 5 federally qualified health centers, because that's what falls under me, and that's what my role is. And I want this to be I don't want to have a Q&A session at the end. I want you to feel free to just interrupt me, raise your hand, or whatever, ask questions throughout, because that gives me a chance to stop talking, and also just helps to clarify different points during the presentation. So if you have any questions, please feel free to just let me know. So what are health centers? Health centers are clinics that are set up in underserved or low income or under-reached populations. We have 50 years ago, the federal government recognized this need for clinics that reached out to initially less fortunate people, the uninsured, underinsured, underserved populations. Today they've evolved a little bit more than that, but they set up the program 50 years ago. So it's a pretty big year this year. I think there are a lot of things planned, not so much on our part, but some like the National Association of Community Health Centers, celebrating 50 years of health centers this year. So it's a pretty big deal for them. There are 4 types of health centers. There are community health centers, homeless health centers to meet the homeless population needs of different cities. You have your public housing, and you have your migrant health centers. In the College of Nursing, we have federal dollars for the migrant health centers, the community health centers, and the homeless health centers. We do have a clinic in the public housing, the Keystone Public Housing Development, over by the new rec center, Johnson City Rec Center. But it is we don't actually receive federal funding for that. That's under gets funding from somewhere else, but it falls under our scope. So health centers. I told Dr. Corey I'd be talking today a little bit about what is the role of the health center in the healthcare continuum. And so basically, health centers. You can look at this little fact sheet here. The top paragraph, what are health centers, gives you some key points as to the unique offerings or models that health centers use. First of all, they're located in high need areas, like as I mentioned. So you might have people that, because of transportation, lack of transportation, or other reasons, they're not able to travel to other primary care doctors. They're also community directed. And what that means is that for our community health centers, we have a governing board that's set up for those health centers. It helps to direct the services that we provide at the health center. And that governing board is composed of primarily patients from our health centers. And so the HRSA regulations state that you have to have at least 50% of your governing board members have to be patients of your clinic. And so what that does is that helps to keep you honest with the services that you provide. It helps to make sure that you're meeting the patient population needs, because we sit in an office and think that we need to do this, but the patient is really struggling with this, and this is what they want to see, and what the services that they want provided. And one of the unique things about health centers is that we're not just we don't just offer primary care services. We're really set up to offer a lot of different things that really affect the different social determinants of health. You have your primary health care. You also have social services. We have different programs that provide transportation needs for our patients to get to our clinics. And we have let's see, social work in our clinic. You can see some specialty services over there. We have adult primary care. We have pediatrics. We have women's health. We have audiology, speech language pathology. We have physical therapy. We have dental. We have some social services. We just started up a NICU clinic, which is really cool. I can talk a little bit more about our specific services later on. But anyway, so health centers are set up with this unique ability to reach people's needs, not just their health needs, but also some of their social needs. Yes, you have a question?
Can you explain quickly who HRSA is?
Yeah, I'm sorry.
And how you get funding, and then the second part of that is what is the difference between one of these clinics and like a health department?
Health department, right? Okay, that's a great question. So HRSA is Health Resource and Service Administration. It's a division of HHS, federal government. They offer funding for health centers. I'm not sure what the total budget is, but in the state of Tennessee, well, that's not on that fact sheet. Okay, never mind. In the state of Tennessee, I think they pour in somewhere around $40 million to different health centers in Tennessee. You can see the number of organizations on your fact sheet here. There are 26. As of the printing of this, there are 26 organizations in Tennessee that are community health centers, and they have different service sites. There's a total of 187 delivery sites or clinics. So the funding comes from HRSA. It's a competitive grant that you have to apply for. It used to be on a 5-year cycle. Now it's on a 3-year cycle. So we're actually getting ready to go into that competition grant next year. And it's based on your service area that you think that you can reach. So for us, even though we receive federal funding and we were designated as community health centers, if that federal funding went away, ETSU would still operate those health centers because it's not 100% of our budget, but it is a pretty substantial part of our budget. So it would be on a limited capacity if that funding went away, but there would still be ETSU clinics. So our service area, or the area that we write the grant for competition, is Washington County and the schools up in Hancock County. We have the school clinics, and then another community health center network has the rest of Hancock County. They're quite a bit larger than we are, so they have the rest of the counties around. Well, most of the counties around here, and there are a couple other organizations also. So it's on a competitive application base. What was your other question?
The difference between
health departments.
These clinics and health departments. Okay.
So health departments are also great resources. We work in conjunction with the health departments. The main difference is that health departments are set up to they offer primary care services mainly for adults 19 to 64. Okay, so if you're a kid under that in Tennessee, if you're uninsured, then you can get on TennCare. And so you don't go to the health department because you have insurance. And so you can go to other primary care providers. You can come to the health center, we offer, we do bill insurance. We see uninsured and insured patients. I think our 48%, we just did the numbers for last year, 48% of our patients across our community health centers are uninsured. The rest of them, I think we have about 30% Medicaid, and then broken down into other very small percentage of private insurance, Medicare, and then I think that was it. So the main difference is the services that are offered at the community health center versus the health department. The health department also facilitates a lot of disease investigation, public health programs. We at the community health center, while we offer some education and stuff like that, we don't do these broad. Our funding doesn't cover the mass public health campaigns that the health department puts on. We help in those. We provide data for their to support their research and their programs, and we provide the manpower to help out with some of those things. And we do referrals. Like the health department sometimes gets grants that it costs us a lot to offer those services at our health department, in our health center, and so we refer patients to the health department. They refer patients to us. They'll do pregnancy tests at the health department, but they don't do ongoing prenatal care. So a lot of those patients come to us from the health department. So that's the main difference. Main differences between the health department and the community health center. So we work together a lot.
Their funding structure is set. I didn't realize that you were, so every 3 years, you say competitive, means you've got other people that are vying for those same dollars within the same community, or is it that it's pretty well set that, look, this is our niche, we're not going to have anybody competing for the grant in our county, or?
Well, HRSA has set up measures to really see how you're doing. We're getting ready to submit those on February 15th. Those are called UDS measures, Uniform Data System. And it goes into, actually a lot of the data on the back are some of those measurements. Hypertension, diabetes, all that stuff. There are different measurements for how those things are addressed in your health center. Do we do tobacco screening? Do we do what trimester of care are pregnant patients in when they come to our clinic? That sort of thing. What's the birth weight of the babies that are born? Is it a low birth weight? Is it a healthy birth weight? All those things go into our UDS measures. Those are measurements that HRSA looks at to really evaluate how we're doing. We have to set goals and then submit those measures. And if we're not meeting those goals, then we have to provide an explanation of that and really kind of dive down into the details of why we're not meeting those, colorectal screening, stuff like that. There are grants out there that we just actually got a grant to assist with the colorectal screening, because that's one of the measurements that we weren't doing very good on. And I don't know if it's just provider preference. They don't like to do that. I wouldn't. So this grant just provides additional assistance to help get those numbers up. Of really talking to our patients about colorectal cancer. Are we doing the screenings? Are we getting the tests back? Stuff like that. So it's a competitive thing. If you're not meeting your numbers, then HRSA is more likely to. Most of the time, as long as you're making a good effort, then you're good. But especially here where there's only a few. There's in Northeast Tennessee, there's two, us and Rural Health Services Consortium, and then you get over more towards Knoxville, and there starts to be about 3 or 4 different organizations over there. If you get into big cities, Los Angeles, for example, I was out there for training, and they were talking about how there's so many health center organizations in LA. And they overlap, their service area overlaps, that's really competitive, because they really have to be meeting their numbers and showing that they're putting those dollars to good use. So I don't want to say that we have it easier, that we don't have to be as accountable, but there's just not the competition in a more spread out area that there is in a more concentrated area.
And I don't mean to dominate, but we've got some quality students in here. Can you give examples of some of the metrics that you like, colorectal screening?
Mm-hmm.
When you say meeting those numbers, what do you mean? What are some specifics? What are some things that you have to report and track? And
Yeah, that's it. Those are great questions. So, so we have different measurements. As I mentioned, UDS measurements are some of those measurements, and so colorectal screening is one of the measurements, and we have to our patients that fall in that are above 40, that are older than 40, that are in that age range where they need to be checked every so often for, have a colonoscopy or whatever. Are we asking them questions like, when was your last colonoscopy? Are we doing any sort of follow-up with them? We have to have, I think our goal for colorectal screening is 90% of our patients in that age. I won't tell you what we were at 2 years ago. It was 10%. But so it was really bad. But we're working on that, trying to, to improve that. Smoking cessation and tobacco usage. Are we providing counseling during the visits to patients to tell them the harm of smoking, especially the pregnant patients? Are we offering them any smoking cessation help? Anything like that? Our goal there is 100%, because that's something you should be doing with all your patients. And I can't provide you with all the numbers for where we are right now, because we're still gathering that data, because it's due the 15th. But I think we're doing pretty well on that one. Pap smears, are we checking with our female patients who are appropriate age? Have they had a recent Pap smear? If not, are we offering one to them and getting them to do that? Trying to think of some of the other
hypertension.
Yeah, hypertension screening. Are we doing that? Cholesterol. Some of those measurements. And then some of the other measurements are dental. Are we offering dental services to a certain percentage of our population? And so all those are some of the metrics that we do. And then that actually brings up a good point, because Dr. Corey asked me, okay, so what are some career recommendations or some observations that I made, like, I didn't even know this existed until I got out of school. Really, the one that I've learned a lot about, or really need to learn more about, is quality after from our health center perspective, because we have a quality and compliance manager. We did have a quality and compliance manager. He left and went somewhere else.
So you added him.
Yeah, for the time being. Obviously that's something I need to learn more about then. But that's a whole field that career opportunities. If people are interested in quality, if people are interested in compliance, there's a whole field and a whole need, and that's just in community health centers. You get into hospitals and things, and it's a whole different ballgame. So. Yes.
You said that ETSU would run these clinics if you lost the funding for this. What about other sites? Are they run through alongside a sister, a sister organization, or if they lose funding, do they go away?
Yeah, that's a great question too. Excuse me. So we have a very unique and convoluted system that we try and run. It's called a co-applicant agreement. Our governing board is a separate nonprofit, and or we have a nonprofit entity, and the governing board is the governing board of that nonprofit. They are what's called a co-applicant with ETSU for this grant. And not all health centers are set up like that. Most health centers, I think about 20% of all health centers are co-applicants. It's really, especially when you partner with a state university, because there's a lot of hoops that you have to jump through, state regulations. It's a very tedious process We've been a health center for going on 12 years that we've been receiving this funding from HRSA, and we're still working out the kinks of the relationship between the governing board and ETSU. So it's very, it's confusing. Other health centers are independent, the other 80%, and so they don't have a sister organization or a co-applicant. So most health centers, this is supplemental funding for them. There are very few health centers that the HRSA money is 100% of their budget. And so, it just depends on the health of the organization. If that funding went away, what percentage of their budget would go away.
So that brings up so why do this? Is there revenue? Is there an income from this? Or is there, what is the reason for it? Maybe that 80%. I don't know if they're, obviously private organizations that are with other sister organizations. Why do they do it?
They're nonprofits. They do, they're service organizations serving the community. You have a lot of faith-based organizations doing that. You have some you also have a lot of not faith-based organizations that are federally qualified health centers and serving the community. I think the reason for doing it is because of the incredible need, there's just a gap that a lot of people, there's 23 million people across the nation are health center patients. I think it's 1 in 12 or something like that. 1 in 12 Americans get their primary care at health centers. So there's a huge need. The uninsured or underinsured, we have a. I'm trying to tie this in. We have a sliding fee at our community health centers, a sliding fee scale. So if you come in, the federal poverty guidelines are guidelines that the government uses for different assistance programs, whether it's housing assistance, whether it's TennCare, whether it's food stamps, other things like that. So the federal poverty guidelines go up to, I think, 250%, and actually I think they go up to 400%, but we go from 250% on down. If you fall into those categories, then then you can qualify on a sliding fee based on where your income reaches, where your income is for a discounted rate for the services. So if you come in and you are 100% and you have a hardship, you lost your job or something, then you can actually get the services at our clinic for free. You have to prove that hardship. Because a lot of people think that we're a free clinic. We started out as a free clinic 25 years ago, but we are not. But we're a federally qualified health center. We have been for 12 years, and we have HRSA actually puts regulations on us that we offer services to people that are really in need of them, but we don't just offer free services to everybody. We actually have to make a good faith effort to collect and to do our due diligence. But anyway, so if you fall above that 100%, between 100 and I said 250, but it's 200%. If you fall between there, then based on your income, then when you come into our clinic for, let's just say, a primary care visit, you don't have insurance, then you would qualify for a sliding fee, 100%. I think we just redid it. I think it's $25 for 100% if you're between 100 and 125%. If you're above 125% to 150%, goes up to 35, 45, 55. And that's a whole lot better than being charged, I think it's $170 for a primary care visit. So those are, that's one of the advantages of being a federally qualified health center. You can meet that gap of the uninsured or even underinsured. If you have insurance and you still fall in that gap, or you still fall under 200% of the federal poverty level, you come into our health center. Because we're a federally qualified health center, you can actually qualify for that sliding fee also if you have a high deductible plan. So if your deductible is $3,000, and so you'd be responsible for paying, depending on what you're getting done at our clinic, $350. If you're on that sliding fee, then you could actually receive a discount on those services, even though you are insured. In the private sector, and if you're not a health center, that's fraud. but because that's insurance fraud, but because we're a federally qualified health center, we're able to do that. Jack, do you have a question?
Yeah, you have been talking about insurance.
Right.
Yeah, and there are two things currently going on. You said about 48% of the population are uninsured population. So, have you guys been discussing any issue about the possibility of your population maybe moving to other health services? Should Tennessee, the Insured Tennessee issue passed the General Assembly?
So we have, so with the Affordable Care Act, we had hope that our 40, it actually higher before, about 60 to 70%, depending on which clinic we were at, of our patients were uninsured. When the Affordable Care Act was passed, a lot of states saw a big shift from their uninsured population to Medicaid in particular. Tennessee did not expand Medicaid. So it's a whole nother talk for how people qualify for that and everything. But the basic is if you there's a gap that people can fall into if they're between 100% and 133%, they don't qualify for Medicaid if the states didn't expand, but they also might not be able to afford the insurance through the marketplace. So in Tennessee, that means that there wasn't a big shift from our uninsured population to insured. Now with Insure Tennessee, we are hoping that will be a big shift for us from uninsured to insured, but we also do see a lot of patients that still may choose, one, not to participate, or two, still may not be eligible, because we do see a lot of people without social security numbers at our health centers. And so if you don't have a social security number, you're not going to be able to sign up for the Insure Tennessee program unless you're pregnant. Then you can get temporary coverage. So we're anticipating that there will be a big shift, but how big we don't know. We'll still have a pretty high percentage of uninsured patients. In the healthcare continuum, to go back to that, you have, it's a big puzzle. There are lots of different pieces in the puzzle. Health centers, primary care, in general, is one piece of that puzzle. And your other specialty services are other pieces of that puzzle. When your patients are uninsured, it's really hard to get them those other pieces of that puzzle, the healthcare puzzle, because they have to pay out of pocket for those specialty services unless you can get them in with an organization. In Johnson City, there's an organization called Project Access. They offer services to specialty services to patients that qualify. There's always qualifications for these services. But then you get into that, and there's so many patients that need those services, they have a waiting list of who knows how long. It's not an urgent need. So getting your uninsured patients the specialty care that they need is really difficult, sometimes impossible. So a shift to insured patients with Insure Tennessee, that'd be huge for not only us, because even though we're a nonprofit, so we don't have investors that we cut a check to if we make a profit or anything like that. But if we don't have a profit, then we don't keep our doors open. We don't have a mission if we don't make money. And so because we're not 100% grant funded, and even if we were, then grant funding goes away and you close your doors. So anyway, so we that's a good thing for us to shift from the uninsured to the insured, but then it's an even better thing for our patients, because then you're able to provide those specialty services to them and get them the full care that they need. Any other questions? Yeah.
Will you ever, like you started out as a fully free clinic and now you charge the fee, will you ever go to a place where you can sustain yourself, or will you always need funding from either ETSU or this grant?
That's a great question. We Our strategic plan is to eventually be self-sustaining. That's a lofty expectation. We actually don't receive any money from ETSU. We don't receive any state funding through the university. Our funding comes. We do receive state funding, but in the form of our payments from our safety net payments for the patient population that we see, and then we receive revenue from Medicare, Medicaid, and then the third-party insurances that people have, and then actually the patients that walk in our door that are self-pay patients. That's a small part of our revenue as well. I think about 60%, 50% of our budget right now is grant funding. So it's a lofty goal to move towards, the next 5 years, 3 to 5 years, to move towards that being self-sustaining. That's the idea, but there's always things like that.
Thanks, Alice. Are there nurse faculty that have clinical workload that is donated to, or I guess paid for by the clinic? How does that work with respect to the ETSU side?
Let's see, the faculty that do practice in our facilities, most of so the model used to, let me back up. The model used to be that the Johnson City Community Health Center, it used to be called the Johnson City Downtown Clinic. That's what it was founded as. The idea was to reach the homeless population of Johnson City. And that was run completely by faculty. They had their workload of teaching, and then this was a way for them to keep up their clinical hours, by seeing homeless patients in Johnson City. Now, 25 years later, we've moved around the city, different locations, and now we have this great new location that's 2 years old that was federally funded, and it's a whole different ballgame. Moving towards that patient-centered medical home, and just having everybody having your primary care home be our clinic, so that we can coordinate all the services that you need and coordinate your care. Now we have our staff are almost 100% over at the clinic, so we don't have a faculty load. Some of the other clinics in the college outside of the community health centers, some of those are more the faculty-based model. But that's kind of outside I don't delve into that too much because that's outside of I've got enough on my plate. So I'll let somebody else deal with those.
Thanks.
Yeah. So I can't answer your question 100%.
No, that's a great answer to the question. What I'm trying to figure out is how where natural teams, like research teams or something else might fit based on the type of faculty that might be there. So I was just trying to get some information to see if there's a way to reach out.
We have different interprofessional teams that do there's a IPE clinic at the Johnson City Community Health Center School sometimes, and so we have different opportunities like that. I think Dr. Van Hook would be able to direct you more in those areas. Thank you. Okay. So we've kind of covered a lot of things with the questions, so that's great. Trying to look here and see if there's anything to go back on and touch on. I can talk a little bit more about things that I started out. My undergraduate and my graduate were in community health, and so getting into administration, it's not something that I thought I would do. But then, so I guess one of my recommendations or takeaways on my time and what I hope you guys can glean from it is the field experience was just huge for me. take them seriously, the field experience seriously, because you don't know what, one, what you're going to learn from it, and two, what opportunities are going to pop up because of your field experience. And sometimes you might get a crappy field experience. That's okay.
That's not true.
And or it just might not pan out the way you anticipated, and not everybody gets a job offer or anything like that, and that's okay. But every once in a while, things it really does. It's a good fit for you, or it's a good fit for the organization you're working for. And so taking the field experience seriously is a big thing. I did my field experience, my graduate field experience I did with the College of Nursing, with the Johnson City Community Health Center mainly. I was dealing with, let me think back. I was working on BMI screenings, and pulling together some data for that and trying to get that measurement, trying to develop a way for education and for the providers and the patients on BMI and getting that measurement up because they were kind of low in that area. And then I started working, when I graduated, there was an opportunity for me to work, to stay with the College of Nursing and to work as the outreach and enrollment coordinator, for the health insurance marketplace. And so I did that for, a little over a year. And so anyway, so that's, so the job came out of that, was great. So I guess my main thing is to, take time looking into what you want to do for your field experience and take it seriously, because you'll learn a lot. So that's the big thing. Yeah. Do
you feel like a quality class is needed, whether you're HSA or community behavioral health?
Yeah. Yep, I do. I think quality, it's just so broad. It just have to be, there's just so many aspects of quality. But yeah, I definitely think that, quality class would be hugely beneficial. And actually, hardly any of my, no offense, hardly any of my classes were in my electives or anything were in administration, because I did community health, and then I did a lot of my electives. I almost had enough for a certificate in epidemiology, and so I thought that was more the track I would be taking. But now in the role that I'm in, I get the administrative aspect of it that I'm actually finding out that I really enjoy. But then at the same time, I'm still really serving the patient population, the population that I started out in public health anyways. Wanted to go into community health to help underserved populations, and so now I can do that on a broader level across all of our clinics, and so it's really neat from that perspective. I don't have as much one-on-one patient interaction. Unfortunately, a lot of times when I do have patient interaction, it's an intervention. Somebody's upset about something, and so then I have to talk to them and see what we can figure out. Do you have a question?
Yeah, you kind of led right into it, actually. What plans or what do you do in terms of evaluation of your services based on your population?
Yeah, great question. We have, we do, last time, and we need to do it again. But last time there was a community needs assessment. It was a partnership between, it was like the United Way group that was doing it in the area. So there's that aspect for the community in general, or the broad community. But then as far as our patient population, as I mentioned, we have board members who are 50% of our board members have to be patients of our clinic. So they have to be able, so that they can evaluate the services that are needed and necessary, and if we're meeting that need. And then we do patient surveys, more in-depth needs assessment survey annually. So for our patients specifically. Yeah.
So as you mentioned in your strategic plan, I guess you said that was maybe 5 years. I don't remember how many years you said that intention of becoming completely self-sufficient, how do you maintain your mission, vision, and values? Or you wouldn't change those, I wouldn't assume. But how do you maintain the mission, and vision, and values of the organization and still move in that kind of model? Because wouldn't that fundamentally change the way you do business and the way you treat patients and the kinds of patients you treat?
Right. I think that that's another great question. So 20 years ago, 25 years ago, everything was given away. Like all the services, all the supplies. Your patient would come in and you'd be like, oh, here, take some for the road. Take some extra bandages to use at home, or whatever. We still have, so now, there's not as much grant funding available as there was 25 years ago for our purposes. Some of the grant funding is kind of in question as to the how long term it's going to be around. So there's a push that we just have to move in that direction. And then with our growth, being able to we've expanded our services, we've expanded our sites and everything, so there's more of a need. It's not just a little. It started out in the basement of the Salvation Army, so just little tiny clinic, and so now we have a lot more resources, a lot more staff, a lot more processes and stuff that were going on, a lot more expenses, and so we have to kind of maintain that revenue a little bit more. So you do it in so to maintain the mission. The strategy, I would say, is that it's all about your patient mix that you have, because you can have you can have Medicare patients, and you can have that are insured, and so they're good patients to see. They come in for routine visits, and you get reimbursed for it, and it's great. But the Medicare population also a lot of times has their established provider that they've had for a long time, and so it's a very small percentage of our population. Increasing your pediatrics, especially those on TennCare, is a good strategy for us, because those are all insured patients that can then help fund, the other the sliding fee patients and the other services that we provide at lower cost to our patients. So it's a balance. You don't want to, and it's a culture change, and honestly, we're struggling with it, especially some of our not older, but some of our providers that have been with us for a longer time, that came from this model of, here we're this charitable clinic and we're giving services away, and now administration is telling us to, that we can't do that, and we need to tighten up on things and stuff like that. So it's a culture change, and it's trying to get people to understand that just because we're trying to be more frugal does not mean that that we're turning our backs on the population that we're trying to serve or anything like that. It's just you have to have revenue, you have to be able to have that income to be able to keep your doors open. It's just the facts. Yeah, actually.
So I was having worked in that basement in the Salvation Army, it's better now.
Yeah.
From a societal standpoint, your view, does the providing very inexpensive or free health care, does that really foster individual ownership of people's health?
Mm-hmm.
Are we shooting prevention in the foot by giving everything away?
I think you see a mix of people. A lot of our patients are working. We've got patients that are working 3 jobs. None of them are full time, so none of them have benefits. They're a single mom with 3 kids or something like that that's working 3 jobs trying to keep things together, and they just can't afford health care at other places, and so they come to us and still pay that nominal fee that we charge them. So you do have those patients that are taking ownership of their health care, their family's health care. Then you do have a lot of patients that, just trying to work the system and get whatever freebies they can. It's difficult because there's a fine balance between a patient's ability to pay and their willingness to pay. And so one of our jobs is trying to differentiate the two. When a patient comes into us, claiming hardship, is it, but then they have things about them that might lead you to believe that they have more money than they're leading on to. The way they dress, the technology they're using, stuff like that. Then it's very difficult at that point to differentiate. Okay, well, not to differentiate, but to be like, okay, you're claiming hardship, but the paperwork says that you do not have this hardship, and so we try and differentiate, but that's such a touchy subject, and we are required by HRSA, because we receive the funding, that if patients fall into that into the hardship, then we give them services for free. If they and a lot of times we're trying to increase our collections, but a lot of times patients just don't pay. So we're trying to implement things to pay for any specialty care beforehand, stuff like that. If you're going to get lab work done, you have to pay up front. But some of the primary care visits where they come in because they might have the flu or something like that, and then we see them and then they don't pay. So you do have those people, and unfortunately, I think the system works both ways. I think that it helps I think that having the nominal fees and the sliding fee keeps some people accountable, and then other people, no, it doesn't. Good question. I think that's a lot of the debate right now with the Insure Tennessee also is the individual responsibility.
So Silas, to what extent do you feel that the community health centers here in Washington County are able to meet the need of the uninsured or the underinsured population? Do you have waiting lists? Do you turn people away, or do you actually reach out to your potential service population?
Right now, we're trying to really up our marketing. We have capacity to grow right now within our clinics. As far as reaching the population, I think there's still a lot of need out there, and we're trying to up our marketing on that. One thing that we've implemented different things for like waiting lists. We don't do. We have walk-ins. You can just walk into our clinic and you'll be seen that day. We don't turn anybody away. That's one of the things that we just recently implemented. And so that means that, a lot of times, and we also have extended hours, which is really great for the working population that doesn't have insurance, doesn't have benefits. They can't take time off work to come to the clinic. And so we're open till 8 o'clock at night, and then we also have Saturday hours. And so that's really great for our working patients. And so we don't have a waiting list. Well, actually, some of our specialty providers they have waiting lists. So that's something that we just don't have the capacity to meet the need of the community for a lot of the specialty care. But as far as primary care, we're pretty able to handle what comes in our doors right now. We're just trying to find the balance of that. We're trying to find new business opportunities, whether it's reaching out to schools or assisted living facilities to get that Medicare population, stuff like that.
My question is, to what extent did the education that you had here prepare you for the position?
I think I would have been more prepared had I decided to focus more on health services management policy. little.
You notice he got the job.
But, I think those gen eds, you know, the core. I think the core, you know, being well-rounded with all the different core, the core classes and everything. I think, you know, I don't feel like I know what I'm doing, you know. Yeah, you know. But I do think that my education here, with the, you know, you hate the oral intensive and the writing intensive. I don't even know if it's still labeled as that or what.
They
But,
are.
you know, like you hate those classes, but then you get into the job environment, and you're like, I'm really glad that I had that. I'm really glad that you know, that Dr. Corey, you know, looked over my you know, my papers that I submitted, and, you know, told me how I could do better, you know. And so just having that scrutiny and stuff, it's, you know, annoying when you want that, you know, when you want that 99 on your paper and you know, you don't get it. You know, you come later and you're like, you know what, I'm really thankful for that. So I think that the writing and the speaking is a big thing that I felt fairly prepared for. I didn't write any grants when I was in school here. I still haven't written any by myself, but, you know, I've been involved in some of those processes. So, you know, that's, you know, I wasn't prepared for that. You know, but I think part of that is on me, because I had opportunity, you know, with Dr. Pack or Dr. Stutz. I think we wrote Dr. Stutz and I wrote a couple small internal proposals, I would call them, rather than grants. But, you know, so you can take advantage of different opportunities that are available to you. And even if you don't feel like doing it, you need to do it sometimes.
So, one last question.
Mm-hmm.
I really appreciate your presentation. I thought it was really well done, very, very relaxed, and clearly you took a class that gave you diplomatic, hard question answering skills. So it must have been a community health class. Anyway, so your advice about the field I thought was great and dead on. We hear that over and over and over. Second level advice. This is your chance. Unsolicited advice, other than, you know, taking the feedback in the classroom, well, and that sort of thing.
So for the program, so you're talking.
No, for your audience here.
Okay.
Unsolicited advice.
Yeah, I think, man, for me, it just goes back to even the experience outside the classroom. The classroom stuff is great because it teaches you the basics that you need. You know, so I'm not knocking, you know, classroom work at all, because that's your foundation. But actually being able to figure out how you can apply that. You know, you wait till you're a salaried employee trying to figure out how to apply the things that you learned in the classroom to your job, and you're going to be spending a lot of late nights working on that. So I'd say take advantage of just even little opportunities that you have. Definitely come volunteer. Community Health Center will take volunteers. We've got a lot of cool programs going on, and just different things.
Skills and encounters.
Yeah.
You've got one.
I think that's great advice, actually. Basically, it's engagement. You know, kind of getting connected, and you know, in your time here, Silas, I got to witness a lot of it. And one of the hallmarks of your time as a student here was you were around all the time. You know, I mean, you were always kind of getting the stuff done, whether it be at Valley Brook or helping out the dean's officer and doing these types of activities. And I think that level of engagement, I think that you're absolutely right. That engagement outside of the classroom is very, very important.
Yeah, it's the experience that.
And that can be, I mean, that engagement can be through the Public Health Student Association or through the Student Council or through other class project or other opportunities, that come up. So there are really multiple opportunities, for students to engage. You just need to take that initiative and approach PHSA or approach the student council or approach your faculty expressing interest in special projects. So because that really, again, not only beefs up your resume, but also gives you those cross-cutting competencies that Silas is talking about, and the life experience that is so very valuable for your next phase.
It's okay. So while she's feeding my mind while she's talking, so to get back to the oral intensives and the writing intensives, my point with that was just saying, like, a lot of times with your electives, the mind. And do you guys still do electives? I know you're changing some things. Okay.
Yes.
Okay. So I think a lot of times with electives,
I'm sorry, for the MPH we still do.
Yes,
for the
sorry.
bachelor's, not many, but for the MPH they still do
Okay.
3 electives. Yes.
Okay. A lot of times they're maybe not at the MPH level so much. Just take advantage of, branch out. I ended up in administration, and I didn't think I'd be here. So looking back, I wish I would have branched out a little bit more with my electives and stuff like that, to gain a little bit more experience in that area. There was another thought I had, but it escapes me. So you don't get that too big.
Yeah, one quick question. What kind of volunteer experiences do you offer to the community health public health students?
For public health students, we right now, I would have to talk with our volunteer coordinator to see what all is going on. But any time that, especially epi people or biostats, if you have, if you want to get your hands dirty working with some data, we've got all kinds of projects that we could use you for. The community health, more health education type things. We can find things and be creative. I mean, if you just want to get in the door and do some volunteer hours, just doing maybe not even what's in your area. If you want to sit with the front desk people and just see the patient population that comes into our clinic and do things like that, then we can set lots of different things up for you. We have the other 2 clinics here in Johnson City. One is the downtown day center, and that's kind of a carry-on of our original mission of reaching the homeless population of Johnson City. It's a place for homeless patients to go during the day. That came about because out of the Salvation Army, we moved to another location. Then when we outgrew that, when we moved to another location, and our homeless patients started going to the second location. When we moved the 3rd time, said, well, we don't want to go anywhere else, because that's that new building that you went into, not this one, but a previous one. That's too nice. We feel uncomfortable there. Can we stay at this other site? And so we started another clinic. And that's kind of where, carrying on that mission there, they still get referred to, our main clinic for different things. And then we also have a clinic in the public housing, over in Keystone Housing Development. That's just a small clinic. We've got 1 provider and 1 front desk person and a nurse over there. So.
Okay.
All right. Thank you
Thank
so much.
you very much.